Good afternoon, chairpersons and my dear colleagues. My today's topic is novel technical approach to a difficult PCA made easy. Though it is a radial session, I have given its femoral. To introduce, the PCA has been simplified greatly over the last decade due to improvement in the hardwares and also technical. However, there is a failure up to 50% in a complex coronary lesions like type C, calcified and tortuous vessels. There are different techniques to improve the guiding catheter support and facilitate device delivery. So my case is 49-year-old male is a diabetic hypertensive presented with acute infeval MI. So he was thrombolized and stabilized in ICU. So he has also a past history of old anterval MI in 2008 for which he was continued to be on medical management. His echocardiogram showed LV dysfunction of 45% and thin and akinetic anterior and septum, hypokinesia of infeval. So he underwent angiogram after stabilization. So angiogram showed left main was normal. There is a mid-distal LAD was totally occluded with a diffuse disease distally, whereas LCX is non-dominant, tortuous. It has 80% long segment stenosis, whereas RCA, if you look at the RCA, it's a dominant vessel which is tortuous in the mid RCA and multiple lesions in the distal RCA. So for him, we have given an option of bypass versus angioplasty, and he was not keen on bypass. So we planned angioplasty to LCX and RCA after 1 week. So the patient, LCX we took, it's a 6 French EVO guiding catheter, BMW wire was easily crossed, and 2 into 10 balloon was used for predilatation of the lesion. So after predilatation, we took a 2.5 into 38 DES, which we could not negotiate through the tortuous and lesion. So we decided to use a guideliner catheter. So to few words about guideliner, it is a guide extension catheter which is around 20 centimeter length, which is connected to a steel push tube with a collar, so which can be used in a standard guide catheter as a monorail system. So it is made up of 3 materials. There is interiorly that is PTF and it is supported by a steel coil, and outside it is a Pevex polymer which slides into the guide. So we should be warning here is guideline, we should use only 10 centimeter beyond the primary curve, otherwise the steel wire may come out of the primary curve. So with the guideliner help, so the stent is easily crossed into the LCX lesion and dilated and post-dilated with 2.5 into 10 balloon with 16 atmosphere, giving the final results. The final result is well opposed stent with a good result. So then we decided to do in the same setting the RCA angioplasty. You can see the angiographic picture where there is a difficulty in crossing the tortuous RCA and the lesion. So you can see the right side of the angiogram showing the difficulty in even a new balloon pushing beyond the tortuous vessel. So we used the same guideliner up to the mid RCA. So there it facilitated the passage of the balloon even into the tortuous area and also the lesion. So adequately predilated. So then the long stent, it's again here we used 2.75 into 38 sirolimus eluting stent. So even with the guideliner, so we can see there is a difficulty in pushing the the stent across the lesion. So after deeply engaging the guide, so we were able to maneuver the stent into the lesion. So after positioning, deployed and post-dilated with 2.75 into 10 balloon with 16 atmosphere. This is the final result. So what is this case? The guideliner catheter greatly simplifies a complex procedure when you have a tortuous or a calcified vessel, so which reduces the contrast load to the patient and radiation minimizes for the patient and the doctor. So this advantage of the guideliner is we can atraumatically and deeply engage into the coronary system without any dissection. So it is also advantage over other guiding like arterial mother-child concept in that. So you can use the same guiding system and a 2E system, and it is a monorail, so you can fasten the procedure. Thank you very much.